Welcome to this deep dive, where we try to pull out the key ideas from, well, often pretty dense research papers and make them clearer. And hopefully a bit interesting too.
Hopefully.
Today, we're looking at a really fascinating bit of machine learning research. It's tackling a big problem. Figuring out why people keep having negative health events, like ending up back in the ER or getting readmitted to the hospital.
Yeah, it's a huge issue. It affects so many people, and the costs are just massive for the healthcare system.
Right. And what seems cool about this paper is that it's trying to go beyond the usual ways of looking at this. You know, the traditional methods can be slow, sometimes maybe impossible, and they often miss the individual differences.
Exactly. This paper uses machine learning, specifically causal discovery techniques, to try and find answers more efficiently and, crucially, in a more personalized way.
So the main idea, the goal, is to make this whole process of finding causes in healthcare data more practical and acknowledging that, well, the reasons aren't the same for everyone.
That's it, precisely. The paper's title is Heterogeneous Causal Discovery of Repeated Undesirable Health Outcomes.
Okay, heterogeneous being the key word there.
Definitely. It's not just what causes these repeat events, but how those causes played out differently depending on the patient group. They developed this framework using an ensemble, like a team, basically.
A team of algorithms.
Yeah, a team of causal discovery algorithms. Think of it like getting multiple experts to weigh in on the data. It makes the findings more robust, hopefully catching more true causes without adding too many false alarms.
And the heterogeneous part helps find those.
Is that
modifiers, was it? Things that change the cause-effect link.
Exactly. Specific characteristics or situations that alter how, say, a particular health condition leads to a repeat ER visit. It's all about tailoring our understanding.
Okay, let's start with the basics then. When they say undesirable outcomes, what exactly do they mean? And why focus on the repeated aspect?
So an undesirable outcome is pretty much any negative, unexpected health event. And repeated just means it happens again within a certain time frame.
Like the examples you mentioned, ER visits, readmissions.
Right. Repeat ER visits, hospital readmissions, which is a huge focus now with healthcare policy, things like the Affordable Care Act penalties, and also things like addiction relapse. They mention a figure, something like $38 billion spent just on ER overutilization in the U.S. each year because of repeat visits.
Wow. Okay, so yeah, understanding the why behind the repeat is pretty important, both for people's health and, well, the economics of it all.
Absolutely.
And this idea of heterogeneous effects. Why is understanding these differences so vital?
Well, this is where it gets really interesting and potentially breaks new ground. Let's say, okay, diabetes linked to repeat ER visits.
Seems plausible.
Right. But that link might be really strong for, say, older diabetic patients who also have kidney issues. But maybe for younger patients who are managing their blood sugar well, the link is much weaker.
Ah, I see.
By finding these heterogeneous effects, understanding who is most at risk under which specific circumstances we can move past these broad, kind of one-size-fits-all interventions.
Towards something more targeted.
Exactly. Developing strategies that work best for specific patient groups. It's like bringing personalized medicine ideas to the population level.
So how does this paper actually suggest we do that? What's the core of their method?
It's an end-to-end framework, really, with a couple of key parts. First is that ensemble of CSL algorithms, causal structure learning.
Right, the team approach.
Yeah. Instead of just one algorithm, which might have its own blind spots or biases, they run several different ones. The thinking is if multiple algorithms looking at the data in different ways all point to the same factor as a likely cause, you can be more confident.
Okay.
They even developed a metric for this cause support, basically, how consistently a potential cause pops up across the algorithms.
And the second part?
The second part is specifically designed to find those effect modifiers and then estimate both the overall average causal effect and these varying heterogeneous effects.
So it tells you what might be a cause and also for whom it's most likely a cause.
Precisely, and under what conditions. Then they tested this whole thing on real data. Big data sets.
What kind of data?
They used a large insurance claims data set looking at repeat ER visits for diabetic patients and also the MIMIC data set.
Oh yeah, the ICU data.
Right, really detailed ICU admission records, which they used to look at hospital readmissions.
Insurance claims, I mean, aren't they mostly for billing? How much actual clinical info is in there?
Surprisingly, quite a bit, actually. You get diagnoses coded with things like ICD-10, procedures, medications sometimes, and the patient's history over time gives you a picture. It's not perfect, but it's a rich source.
And MICV is even more detailed.
No, yeah. Much more clinical depth, diagnoses, procedures, lab results, notes, though here they focus mainly on coded data like ICD-9 diagnoses and other metadata. For the ER study, it was almost 500,000 claims.
Wow.
And for the readmissions, over 300,000 records. So yeah, substantial data sets to test their framework.
Okay, but with real-world data like that,
Yeah.
you don't have the answer key, right? You don't know the actual true causes for sure. So how did they check if their framework was finding anything meaningful?
That's always the challenge with observational data. So they used a few different tactics. First, consistency. They checked if the causes their framework pointed to matched up with what's already known from existing medical research.
Makes sense. If it finds known risk factors, that builds confidence.
Exactly. If established factors for, say, readmissions kept popping up, that's a good sign. Second, they did something pretty novel. They used large language models, like ChatGPT,
Really?
kind of queried them based on their vast training data to see if the LLM identified similar cause-effect relationships. An interesting sanity check.
Yeah.
And third, they ran experiments on simulated data. This is crucial because with simulations, you do control the ground truth. You create the causal links yourself.
So you can actually measure how well the algorithms perform, like accuracy.
Precisely. They could check how often their ensemble correctly found the true causes and how often it made mistakes, false positives or negatives.
Got it. So summing it up, what did you say are the main contributions here? What's new?
I'd say there are three main things. First, the problem formulation itself. Jointly trying to find both the causes and the effect modifiers when there's lots of uncertainty. That's quite novel.
Okay.
Second, the methodology. Using that ensemble of CSL algorithms and the cause support metric to quantify confidence, that's a neat innovation.
Right.
And third, the real-world impact.
Hmm.
Showing this framework can actually yield potentially useful insights for these really important, costly healthcare problems, the repeat ER visits and readmissions. They also make a point of distinguishing their work from methods that just look at event sequences, arguing that diagnosis timing isn't always the same as when a condition actually starts.
Okay, before we dive into their specific findings from the real data, maybe we should quickly touch on some of the core concepts they're using, like what exactly is a structural causal model?
Good idea. So a structural causal model, or SCM, is basically a mathematical way to represent the underlying process that generates the data. It involves variables, things we measure, things we don't, and functions that show how variables directly cause others.
And often visualized with those diagrams, DAGs.
Exactly, directed acyclic graphs. Arrows show the causal flow from cause to effect. No cycles allowed.
And effect modifiers in that context, how do they fit into the DAG?
Right. So an effect modifier, as we said, changes the strength or direction of a cause-effect relationship. In the DAG framework, they're variables that aren't caused by the treatment, the potential cause we're looking at, and don't cause the outcome directly after the treatment, but they influence the relationship somehow. They're always non-descendants of both the treatment and the outcome in the causal graph.
Okay. And what about CATE? Conditional average treatment effect. Sounds important for the heterogeneous part.
Definitely. KT is how you quantify that heterogeneity. It estimates the average causal effect of a treatment within specific subgroups defined by the effect modifiers. So it tells you how the effect differs.
Got it. It puts a number on the difference.
Exactly. Then there's CSL, causal structure learning. That's the umbrella term for the machine learning methods used to try and figure out the DAG structure, the causal relationships, just from looking at the data.
And there are different flavors of CSL algorithms.
Yeah, several types. Constraint-based methods look for statistical independencies to rule out links. Score-based methods try to find the graph structure that best fits the data according to some score. Hybrid methods mix approaches. Functional causal models make stronger assumptions about the math involved.
And they all rely on certain assumptions, right?
Yeah.
Like you've measured enough variables.
Right. Key assumptions include things like causal sufficiency, meaning you've hopefully measured all the important common causes, and faithfulness, meaning the statistical independencies you see in the data actually reflect missing causal links in the true structure. These assumptions don't always hold perfectly in real life, which is a challenge.
Okay, that helps set the stage. So how did they actually structure their analysis for these repeat health outcomes? What did the setup look like?
They used what they termed an event log data model. Basically, for each patient, they track events over time, diagnoses, visits, and importantly, whether they had one of these undesirable outcomes, like an ER visit.
So a timeline for each patient.
Sort of, yeah. Creating a snapshot of their relevant history leading up to a potential repeat event. They focused on patients who'd already had at least one undesirable outcome.
And the repeat was defined by a time window.
Yes, 12 months for repeat ER visits in their analysis and 30 days for hospital readmissions, which are pretty standard definitions used in healthcare. Then they formally defined the two key problems. One, discover the causes of these repeat outcomes, and two, discover the effect modifiers that change how those causes operate. They're upfront about the difficulty of doing this purely from observational data, hence the need for SCMs and CSL.
And they noted effect modification could come from interactions or nonlinearities.
Exactly. It's not always simple additive effects. The underlying biology or behavior can be complex.
So walk us through their actual proposed framework again, the heterogeneous causal discovery framework. How do the pieces fit together?
Right. It's got those two main modules. Module 1 is the CSL ensemble, input, the observational data, plus any prior knowledge, like the fact that the outcome can't cause past conditions.
A crucial constraint.
Definitely. This module runs the different CSL algorithms. Output, not just one graph, but a list of potential causal graphs, plus that cause support score for each potential cause, showing how much agreement there was among the algorithms.
Okay, so step 1 gives you a ranked list of potential causes, then module 2.
Module 2 is discovering heterogeneity. It takes the data again, plus the list of causes and graphs from Module 1. For each potential cause, it first estimates the overall effect, the average treatment effect, or 8EE, using standard methods like backdoor adjustment to control for confounding.
Right.
But then crucially, it hunts for potential effect modifiers. It looks for variables that are related to the outcome or mediators between the cause and outcome, but aren't descendants of the cause itself.
And then it calculates the CV.
Exactly. It estimates the conditional average treatment effect, showing how the effect of that potential cause changes depending on the values of those identified effect modifiers.
Okay, I think I've got the structure now. Let's get to the results. What did they find when they applied this to the repeat ER visits data for diabetic patients?
So using that big insurance claims data set, their ensemble approach flagged several ICD-10 diagnosis codes as having a significant positive effect on repeat ER visits. These are potential risk factors.
And did they make sense clinically?
Yeah, many did. Things like end-stage renal disease, severe chronic kidney disease, heart failure, these came up strongly. Which makes sense, right? These are serious conditions often needing urgent care.
Absolutely.
They also found mental health conditions like bipolar disorder were linked to higher risk, and factors like patient non-compliance with medication or being dependent on insulin, even nicotine dependence showed up.
Interesting. What about factors linked to a lower risk? Protective factors.
They found those too. Codes related to things like encounter for general adult medical exam and encounter for immunization had negative effects, suggesting they might help prevent repeat visits.
So preventative care seems to work, according to the data.
It seems associated with better outcomes, yes, which aligns with general public health advice. They also saw some hints that maybe long-term medication use could be a proxy for better overall management, leading to fewer ER trips.
And the heterogeneity. Did these effects vary?
Yes, and this is really key. Take general medical exams. They seemed less effective at preventing repeat ER visits for patients who also had issues like convulsions or metabolic syndrome, things like hypertension or high cholesterol.
So the context matters.
Exactly. Same for immunization seemed less protective for patients already dealing with metabolic problems or who were getting other services like dietary counseling. It really drives home that you can't just apply interventions blindly. Effectiveness depends on the patient's whole picture.
Okay, what about the other application? Hospital readmissions using the MIMIC-V data. Similar kinds of findings.
Broadly similar patterns, yes. They found ICD-9 codes and other data points linked to both increased and decreased risk of readmission within 30 days.
What increased the risk?
Things you might expect. Surgical complications, bad reactions to drugs, serious chronic conditions like diabetes with complications, kidney failure, hypertension, cancer. Again, pretty consistent with existing research.
Any surprises?
Well, again, the strong link with mental health disorders really stood out. Suicidal ideation, mood disorders, depression were all associated with higher readmission risk. It really emphasizes integrating mental and physical health care.
What about factors linked to lower readmission risk?
They found things like early diagnosis of certain heart complications after surgery being observed for suspected infections, and documented need for preventative shots were linked to lower rates.
Interesting.
Also, how patients came in and where they went afterwards mattered. Direct emergency admissions had higher readmission risk, as did discharges to psychiatric or long-term care facilities. Discharge to hospice, maybe predictably, had a lower 30-day readmission risk.
So taking a step back from these specific examples, what do you see as the really big picture implications of this type of work for machine learning in healthcare?
I think the potential is huge. Frameworks like this offer a way to move towards more data-driven, maybe more efficient ways of identifying high-risk patient groups.
For proactive interventions.
Exactly. By highlighting specific diagnoses or characteristics with strong causal links, it could help clinicians, health systems, policymakers focus resources more effectively. And that heterogeneity piece is critical, getting closer to personalized medicine, but at a population scale, tailoring interventions.
Which could lead to better outcomes and maybe lower costs.
That's the hope, right? Better patient health and reduced strain on the system from these often preventable repeat events.
All right, let's shift gears to our novel notions segment. Thinking about this research, what kind of future ideas or applications does it spark for you, even if they're a bit speculative?
Okay, well, here's one thought. What if you could embed this kind of heterogeneous causal discovery engine directly into electronic health record systems?
Ooh, interesting. How would that work in practice?
So imagine as a patient's data diagnoses, labs, visit history builds up in their EHR, the system could be running these causal analyses, maybe periodically in the background. It wouldn't just spit out a risk score for, say, readmission. It could actually suggest specific, personalized interventions based on the causal factors and effect modifiers it identifies for that individual.
Like tailored recommendations popping up for the doctor.
Potentially, yeah. So remember how the paper showed general exams were less effective for diabetic patients with convulsions?
Right.
Maybe for that patient, the system wouldn't prioritize suggesting just a general exam, but might instead flag the need for more intensive follow-up related to the convulsions, or perhaps suggest a different preventative strategy altogether that's known to be more effective in that subgroup.
So it goes beyond just risk prediction to actual intervention suggestion, tailored by the causal context.
Exactly. A diabetic patient with medication noncompliance might get automated flags for adherence support. One with co-occurring depression might trigger alerts for integrated mental health care. It leverages the heterogeneity findings directly for personalized action plans.
That does sound potentially transformative for preventative care.
Yeah.
What are the hurdles, though? That sounds technically complex and maybe ethically tricky.
Oh, absolutely. Huge challenges. Integrating it seamlessly and ethically into clinical workflows is non-trivial. Data privacy, algorithmic bias, who's responsible if the AI suggestion is wrong, alert fatigue for clinicians. Lots to figure out.
Right.
But given where EHRs and personalized medicine are heading, I could see versions of this starting to appear in, say, the next 5 to 10 years. It feels like a moderate probability, assuming the methods continue to be refined and rigorously validated.
Okay, that's a cool idea. The integrated personalized intervention engine. Got another notion.
Yeah, let's flip the coin. Instead of just reacting to positive causal factors, the risks, what about using the negative causal factors, things associated with better outcomes, to actively design new interventions?
Okay, how would that work? Designing interventions based on protective factors.
Sort of. So the paper found encounter for immunization linked to fewer ER visits for some diabetics. Okay, obvious implication. Encourage immunizations. But could we use the details from the causal analysis, which subgroups benefited most? Were there specific types of immunizations to design hyper-targeted programs, mobile clinics in specific neighborhoods, tailored reminders based on the causal profile?
Going beyond just saying, get your shots.
Exactly. And maybe even more speculatively, what if certain combinations of factors seem protective, like maybe managing condition X and adhering to lifestyle Y together has a strong negative causal effect on readmissions?
Looking for synergistic effects.
Yeah. Could we then try to design coordinated care pathways that actively promote both X and Y for patients identified as potentially benefiting from that combination? It's moving from just observing correlations or average effects to using the causal structure insights to engineer better preventative strategies.
That's definitely thinking more proactively. What's the big challenge there? Seems like you need to be really sure about the causality.
That's the main hurdle. Understanding the mechanisms behind those negative associations. Is it truly causal? Or is it proxying for something else unmeasured? Translating a statistical finding into a practical, effective, and safe intervention is a massive leap.
Yeah.
It would need intense collaboration, ML folks, clinicians, health services researchers, ethicists. You'd need pilot studies, careful evaluation for unintended consequences. So the probability feels lower near term, maybe low to moderate. It's a longer term vision, I think.
Fascinating ideas, though. Really highlights the potential beyond just analyzing data. As always, just scratching the surface here.
Definitely.
For anyone listening who wants to really get into the weeds, we'll put a link to the actual paper in the description. It's the dense read, but as we've discussed, full of interesting stuff about where ML might take us in healthcare.
Absolutely worth a look if you're interested in this space.
Thanks everyone for joining us for this deep dive.